my challenging cases when a hunter came to see me and he wanted to have multifocal vision. But as we all know, kannst du es nicht abspielen?
Ja, okay, gut.
As we all know, hunters, they have to hunt in dusk and dawn. That means they don't like loss of contrast sensitivity. So you can't give them diffractive lenses.
With segmental multifocal intraocular lenses by Detlev Beyer, Hakan Kaimak, Karsten Klabe, Philipp Hagen, Florian Kretz, and Gerd Auffahrt. Why do we need a new MIOL formula? The disadvantages of bifocal IOL, such as halo and glare, and no clear intermediate vision, caused 4% unhappy patients and 1% explantations. In contrast to that, the features of trifocal IOL are less halo and glare, and clear intermediate vision. But these are accompanied by some disadvantages, such as less contrast sensitivity and reading only in good lighting conditions. Anyway, the patient acceptance of trifocal IOL is higher since clear intermediate vision and less halo and glare are crucial for many patients. In 2013, Dr. Beyer moderated the Asia-Pacific Association of Cataract and Refractive Surgeons in Singapore, where Dan Reinstein presented his presbyon laser blended vision concept as an innovative treatment of presbyopia. Here, the dominant eye is corrected for distance vision to almost plano, whereas the non-dominant eye is corrected to be slightly myopic for near vision to minus 1.5 diopters, with a spherical optic resulting in a blend zone of vision. This inspired us to adopt the concept with segmental MIOL for extended depth of focus as a new treatment option for presbyopia and cataracts. We developed a new formula that offers comfort immetropic vision or comfort blended vision according to the individual patient's needs with Lentis Comfort and Lentis M+X. And this is how it works. Near additions and target refractions are combined in different variants. As a tribute to our hometown, we called it the Düsseldorf formula. To achieve comfort immetropic vision, we implanted Lentis Comfort in both eyes with emmetropia as target refraction. For comfort blended vision, we choose Lentis Comfort with a near addition, for example, minus 1.5 diopters in the non-dominant eye, or comfort M+X with the Lentis M+X in the non-dominant eye, according to the individual patient's needs. In 2014, we presented our new formula at ISOP and ESCRS in London. Defocus curves generated from clinical data and the knowledge of multifocal MIOL capacities are indispensable in meeting patients' differing needs. 1 year later, at the next meetings in Barcelona, we presented our first clinically significant scientific results. The strength of halo and glare was defined as the geometric mean of size and intensity and subdivided into 4 categories: none, mild, moderate, and severe. We could show that the Düsseldorf formula demonstrated excellent visual results in far, intermediate, and near, with very few photopic phenomena comparable to our employees aged between 16 and 60. In 2016, at the German meeting of cataract and refractive surgeons in Mannheim, and at a congress of the University of Heidelberg, we presented our latest findings. In the cause of our quality management with MIOL, we investigated the influence of the optical design, near addition, and target refraction of MIOL on photopic phenomena. The results confirmed our expectations. In diffractive optics, higher near addition and deviation from emmetropia correspond with stronger halo and glare. Refractive optics overall have higher tolerance regarding photopic phenomena compared to diffractive IOL. Preoperative evaluation. True corneal shape analysis and measurement of total corneal astigmatism with the LED Cassini. Examination with a corneal aberrometer. Surgery. The corneal refractive information of the Cassini is wirelessly sent to the laser. The iris registration enables us to find the true axis of astigmatism and mark it with the laser. This video shows the implantation of the Oculentus Comfort Toric MF15. Alignment of the toric IOL markings and the corneal marks for perfect IOL orientation. One month after the second surgery.
So, hello, Mrs. Hauck. Now we have 1 month after surgery. You did have a little time to get used to your new vision, I hope. Are you happy with the result?
Very happy.
Very happy, that sounds good. So very happy means that your far vision, intermediate vision, and near vision is fine, despite small print reading. Is that correct?
Yes, absolutely correct.
Where would you think or find yourself? In the maximum, medium, or minimum?
Medium.
Medium. Okay, perfect. Okay, dann kann man das stoppen. Okay. I hope that was a little bit as interesting for everybody, or at least one.
So, thank you so much for your presentation. Do you hear me?
Yes, I can hear you. Perfect.
Yeah, thank you so much for your presentation, Detlev. So you think that refractive lens exchange is a good option when you use a multifocal or trifocal IOL?
Yes, I do, but I think you clearly, and I wanted to make it understandable with a video, you have to talk to the patient and individualize multifocal IOL surgery. Because if you do the Detlev formula, you will not be able to read small print, but you have nearly no halo and glare. But there are also people who say, okay, photopic phenomena, it's not a problem, but I want to read small print. So the most important thing is a visual history of our patients, and then we adapt the lenses. And what is also a little bit nice with the Detlev formula, you can still, if the patient says, I want to have a little bit more far or near vision, if you are further away from emmetropia or your target refraction, you can still do a touch-up procedure with laser vision correction. So it makes it easy to correct this even later on. In contrast, if somebody doesn't like a diffractive trifocal lens, that's it. If he doesn't get around with halo and glare and vexy vision, he has a problem. And here you can still adjust later on, even with a touch-up procedure.
What do you think about varifocal LASIK surgery or multifocal?
I personally, I'm a really big fan of Presbyond laser vision correction, and I just bought a Schwind laser because I also think the Presbymax is a very interesting, good idea. And I do like solutions. If the patient wouldn't be happy, you can go back to zero with easy surgery. I think that you always have the possibility of a way out if the patient is unhappy, because sometimes you lose the patients, they come back after 6 months, another doctor has done capsulotomy and somebody implanted a trifocal IOL. And then you have to explant it. And that's no fun.
So did you stop implanting diffractive IOL?
No. Because, as I said before, I really think there are enough patients, and for example, let's take my population. I implant 90% EDOF or trifocal IOLs, and 40% of them want trifocal IOLs. Even they know they have photopic phenomena. They just don't care about it. So everybody of us is different. He has a different hobby, different business duties. So I think what we have to do as doctors, listen to our patients and then adapt refractive IOL-based laser surgery to their needs, and always put the disadvantages in front. So what I tell my patients first are the disadvantages of what I'm going to do. And then I look at their faces. If they're like, oh, I don't like it, then I don't do it.
What about corneal halos or the corneal abrasion before you implant a diffractive or multifocal IOL? Do you?
I don't want to have it above 0.3. That's for me, is it? I don't care to do after LASIK procedure trifocal IOL. If the aberrations are not above 0.3, I think it's not a problem. If you have a nice optical zone, I do that and have a lot of happy patients. Just yesterday there was one. And a very good friend of mine, she came from Munich, same thing. Many doctors said, no, you can't implant. I said, yes, why? You don't only have 0.2 corneal aberrations, then I implant a trifocal IOL.
Thank you so much, Detlev. Sure, there is a lot of questions. You are going to be with us till you go to your operation. Thank you so much.
Thank you.
Can I comment a little here?
Yes, Lucan. Yes, you have.
Regarding the Düsseldorf formula, I think it's a perfect way to approach the patient needs. In my practice, we also used a lot of oculentis IOLs, and we find that as stated in the video, M plus X combined with lentis comfort is a little bit, there are the intermediate vision somehow is not really good. We used to, when we have hyperopic patients, we combine M plus X with MF20, but we really pay attention to the angle kappa or the visual axis, because M plus X is really sensitive about that, and vice versa. In myopic patients, we tend to go with 2 M plus X IOLs because they are really good in near vision, and frankly, the myopes are not care so much for their far vision. What are your observations, Dr. Beyer, about that?
I'm absolutely with you what you're saying. We just stopped the M plus X due to the reason because I think some of them, they have a really high coma as photopic phenomena. So then I love to combine, for example, in the dominant eye, the LARA, which is the EDOF diffractive, within the non-dominant eye, the trifocal LISA. Because those phenomena, to me, seem a little bit more calculable, like the M plus X. But when I'm traveling through the world and I'm talking to different distributors, it's really interesting how in one country the M plus X is the best and it is planted like a monofocal, and in other countries it's not accepted. This is very funny. I can't really tell you why, but what you said about the angle kappa, how to deal with it, and about the myopes, I completely agree. I just personally don't get around with the M plus X, then I prefer diffractive. But that's my personal thing. This has nothing to do with another country, just my personal experience with my patients.